Inaugurating our 17th year of postgraduate education for surgeons, this is Audio Digest Surgery, Volume 17, Number 1. And to begin this new year, a program on the management of thyroid and parathyroid tumors, 1970, as four distinguished surgeons discuss their various approaches to toxic thyroid tumors, non-functioning thyroid tumors, and hyperparathyroidism. The discussants, Oliver H. Beers and B. Marden Black of the Mayo Clinic and Foundation and the Mayo Graduate School of Medicine, William D. Holden of Case Western Reserve University School of Medicine, and J. Engelbert Dunphy of the University of California School of Medicine, San Francisco. Dr. Dunphy serves as program moderator and starts the session off this way.
Our first presentation, Toxic Thyroid Tumors by Dr. William Holden.
The introduction of isotopic thyroid scanning techniques in the late 40s with I-131 and subsequently with other iodine isotopes and technetium has permitted the identification of hyperfunctioning nodules and the elucidation of their relationship to the remainder or extranodular portion of the thyroid gland. Hyperfunctioning or hot nodules, as they're frequently referred to, may exist as solitary nodules in a gland, or there may be multiple hot nodules. Even when only a solitary hot nodule can be identified by scanning techniques, there may be present small micronodules in the gland. The clinical significance of these micronodules is still open to question. An effort must always be made to differentiate a diffusely nodular, hyperfunctioning, and toxic gland that represents lobulation from repeated episodes of hyperplasia and involution from the toxic gland that truly represents multiple hyperfunctioning adenomas. The former gland represents Graves' disease. Each situation is managed differently, and from the standpoint of therapy, failure to recognize the difference can be troublesome and, on occasion, disastrous. One of the characteristic features of hyperfunctioning adenomas that requires considerable attention on the part of the surgeon is the suppression of activity in the extranodular tissue. The more T4 that is elaborated from the hyperfunctioning adenoma or the adenomata, the greater will be the suppression of TSH. With significant reduction in TSH, there is a progressive lack of stimulation of normal thyroid cells to synthesize T3 and T4, and the total mass and output of extranodular thyroid tissue will diminish. As a generalization, hyperfunctioning adenomas are autonomous and not subject to regulation by TSH. Therefore, as excessive quantities of thyroxine or T4 are produced by the adenoma and TSH production is suppressed, little or no discernible uptake of I-131 can be demonstrated in the extranodular hypoplastic thyroid tissue. Extranodular thyroid tissue, which has been hypoactive or inactive for extended periods of time because of a deficit in TSH production, has a great capability for restoration to normally functioning tissue. This is demonstrated by the administration of TSH and scanning the thyroid tissue even after hyperfunctioning adenomas have been present for years. It is also easily demonstrated by its functional recovery after a hyperfunctioning adenoma has been surgically removed and the hypoplastic extranodular tissue preserved. The TSH stimulation test is performed by administering intramuscularly or intravenously 10 units of thyrotropin and scanning the gland with I-131 or some other suitable isotope 24 hours later. The TSH suppression test is carried out by giving the patient 25 micrograms of T3 triiodothyronine each day for 8 days, and then scanning the gland. If T4 or thyroxine is used, 0.3 of a milligram of levothyroxine are given for 10 days. When thyroid extract is used, 3 grains or 200 milligrams are given for the same length of time. Thyroid extract is the least desirable agent to use for suppression of TSH since it contributes a considerable amount of inorganic iodine to the gland. The clinical manifestations of hyperfunctioning thyroid adenomas develop insidiously and frequently go unrecognized until some overt event, such as atrial fibrillation, calls attention to the basic disorder. Hyperfunctioning adenomas are found most frequently in women over the age of 30, but may occur in men and also in younger age groups. Nervousness, irritability, loss of weight, and excessive appetite may be present, but not strikingly so, as is common in Graves' disease. Mild heart failure, cardiac arrhythmias, tachycardia, and a high pulse pressure are more common findings. Eye signs are notably absent in patients with hyperfunctioning adenomas. If they are found, the patient more than likely has Graves' disease, and the adenoma is incidental. The use of thioureas in the treatment of adenomas which produce thyrotoxicosis has been less than satisfactory, since iodine cannot be utilized for hormone synthesis, irrespective of how much exogenous iodine is provided. The whole process to suppress T4 production in the adenoma takes an extended period of time, and many patients who have thyrotoxic cardiac disease should have their thyrotoxicosis controlled more promptly. The single greatest deterrent, however, to the use of the thioureas in the treatment of toxic adenomas is the fact that rarely can the drug be stopped, since cessation of administration permits the autonomous adenoma to regain its hyperfunctioning state and to recreate the clinical syndrome. The occasional patient who is permanently cured by the use of the thioureas very likely has a spontaneous cure resulting from hemorrhage or necrosis within the adenoma, and it is not due to the temporary administration of the drug. The thyroid hormones, thyroid extract, T4 or T3, are obviously of no use in the treatment of toxic adenomas, since any benefit derived from their use is the result of their suppressive effect upon TSH production in the hypophysis. Since the adenomas function autonomously and are devoid of regulation by TSH, the use of the hormones is irrational. I-131 has been used extensively for the treatment of toxic adenomas, and there are patients for whom this agent is unquestionably the most appropriate form of therapy. I-131 inhibits hormone production in a hyperfunctioning adenoma by the direct effect of beta radiation upon the thyroid cells. In sufficient quantities, it can produce irreversible damage to the adenomatous cells. The difficulty in the use of I-131 for this purpose is estimating the correct dose, which is difficult to do since an appropriate dose is a factor of the hyperplastic cell mass contained within the adenoma. Some physicians have attempted to overcome the effect of I-131 on extranodular tissue by administering a single large dose of I-131 in the neighborhood of 18 to 29 millicuries. The intent is to destroy the adenomatous hyperfunctioning cells as quickly as possible at a time when the influence of TSH on the extranodular tissue is minimal. This is very difficult to do since the rate of uptake and release of I-131 in the adenoma is rapid and calculation of an effective dose is almost conjectural. Some hyperfunctioning adenomas will not be affected by as many as 40 millicuries of I-131. It is almost impossible to create a myxedematous state. The incidence of myxedema after 5 years following treatment of all types of hyperthyroidism, that is thyrotoxicosis resulting from overactive or hyperfunctioning adenomas and Graves' disease, is 30%. But most of this incidence resides in the patient population with Graves' disease. Now, many people feel that myxedema is not a serious complication of the treatment of thyrotoxicosis with I-131. And in fact, it is not if it is recognized early before all the complications of myxedema ensue. This means very close follow-up of each patient being treated with I-131 and an awareness of the subtle nature of the development of myxedema. But too frequently patients are lost, too frequently the myxedema is not recognized promptly, in which event the complications become unusually serious. Patients with hyperfunctioning adenomata who may profitably be treated with therapeutic doses of I-131 are the elderly, those with disabling concurrent systemic diseases, those with a limited lifespan, and those who refuse surgical removal of the adenomata. Surgical extirpation, especially of the solitary hyperfunctioning adenoma, appears to be the most satisfactory means of quickly and definitively eradicating the disease. This is especially true for patients with thyrotoxic cardiac disease, as long as the severity of the heart disease itself is not a contraindication to the surgical procedure, or can be temporarily controlled with an antithyroid drug prior to surgical removal of the adenoma. The preparation of a patient with toxic adenomas is relatively simple compared to the efforts required to attain a euthyroid or a mildly hyperthyroid state in Graves' disease, which is an essential feature of the preparation in the latter disease. Many of the patients with a toxic adenoma and mild to modest thyrotoxicosis require no preparation with antithyroid drugs or inorganic iodine, as long as careful management of anesthesia is available. For reasons unknown, the administration of inorganic iodide in the form of potassium iodide is not terribly effective in reducing hyperactivity of the hyperplastic adenomatous cells, as it is in diffusely toxic goiters. If antithyroid drugs are used to prepare a patient with a toxic adenoma for operation, they should be given in full therapeutic doses and the results of drug administration documented mainly by clinical evaluation. The immediate preoperative preparation of the patient requires satisfactory sedation. Anesthetic agents must be selected that avoid the enhancement of cardiac irritability, which in many instances already exists. Hypoxemia during the procedure or in the immediate recovery state can be disastrous and must be avoided by consistent attention to the airway and to the patient's spontaneous ventilatory efforts. Large doses of narcotics or sedatives in the recovery period should be avoided, especially in the elderly, who may develop respiratory suppression with doses of drugs which would have no such effect in a younger patient. The purpose of the operation is to remove expeditiously and atraumatically only the toxic adenoma, and to preserve as much of the extranodular thyroid tissue as possible. Even when more than one toxic adenoma is present, it is desirable to attempt to remove only the discrete adenomata. Occasionally this is impossible, and a subtotal thyroidectomy is required to remove effectively all hyperfunctioning adenomatous tissue. The fact that a patient has a toxic adenoma does not preclude the possibility of the gland containing cold nodules that may be malignant and were not observed on a scan because of the extensive suppression of I-131 uptake in all of the gland except the hyperfunctioning adenoma. A careful exploration of the entire gland at the time of surgery prior to removal of the toxic adenoma will usually call attention to any other unexpected nodules, since the non-toxic portion of the gland is generally hypoplastic and relatively atrophic. Adenocarcinoma of the thyroid essentially does not occur within a hot nodule. Carcinoma adjacent to the hyperfunctioning rim of an adenoma is not an uncommon occurrence. Postoperatively, patients with a hyperfunctioning adenoma removed do exceedingly well and rarely present the problems commonly encountered after thyroidectomy for Graves' disease. Because of the nature of the operation, the risk of injury to parathyroid glands or to recurrent nerves should be non-existent. Postoperative thyroid storm is absent. Excessive T3 and T4 production is eliminated abruptly by removal of the hyperfunctioning adenoma. Bleeding, the other complication characteristic of thyroid surgery, can only be prevented by meticulous hemostasis during the course of the operative procedure itself.
Paper will be presented on non-functioning thyroid tumors by Dr. Oliver Beers.
By the title of the preceding presentation and this one, it might be concluded that the pathology of functioning and non-functioning tumors of the thyroid gland differs. However, in general, this is not true, since an adenoma might show significant uptake of iodine on scan, but on the other hand, none at all. And also, some cancers under certain conditions will show evidence of function, such as the follicular cancer, taking up significant amounts of radioactivity radioactive iodine, and the medullary cancer, which is associated with the multiple endocrine syndrome and also has been reported to produce serotonin and for patients to have the carcinoid syndrome. Other pathology, however, might exist, and occasionally, because of this, the presence of coexisting pathology with an exophthalmic goiter must be recognized. For this reason, any goiter which is treated by a medical modality should be followed carefully during the period following treatment, just in case the occurrence of other pathology might become clinically apparent, and the occurrence of this pathology can, on occasions, be of real significance to the patient. The various types of thyroiditis will appear on physical examination as nodular goiter on many occasions, and for this reason might be confused as true tumors of the thyroid gland. Careful evaluation of the history, the physical findings, the laboratory findings results in the correct diagnosis in a high instance of cases. If, on the other hand, though, the lesion is suspected of being cancer, surgery must be carried out to establish the correct pathological diagnosis. As you're well aware, there are the three types of thyroiditis that we should mention: Hashimoto's thyroiditis, or lymphocytic thyroiditis, de Corvain's thyroiditis, granulomatous thyroiditis, and lastly, Riedel-Struma, or fibrous thyroiditis. Hashimoto's thyroiditis most often occurs in women. The gland is rubbery firm, most often bilaterally symmetrical, and the laboratory tests would indicate the possibility of Hashimoto's thyroiditis being present. However, the pathologic establishment of this process requires study of tissue. If this type of thyroiditis is suspected, at our institution we frequently will do a needle biopsy of the gland as an office procedure, and in so doing the pathology can be established. If substantiated, the treatment is thyroid replacement medication. However, if this is the diagnosis and if the gland is treated medically, close observation is extremely important for 6 to 12 months, because in 3% of our cases that are treated surgically, 18 of 605, papillary cancers have been found. Also, lymphosarcoma is seen to coexist in the presence of Hashimoto's thyroiditis, again in approximately 3% of cases. So if the goiter does not disappear under medical management over a period of 3 to 6 months, or if there's any evidence of increase in size of the gland during this period of time, then it becomes extremely important that the goiter be removed surgically to rule out significant pathology other than that which is suspected. De Corvain subacute thyroiditis often can be diagnosed by the typical history of neck pain, exquisite tenderness in the region of the thyroid gland, elevation of the sedimentation rate, and a diffuse or a discrete enlargement of the thyroid. When the clinical diagnosis is established, conservative treatment is indicated. However, in about 1/3 of cases of subacute thyroiditis, a typical clinical history and the typical physical findings are not present. In these cases, it then is necessary to establish the pathological diagnosis by surgical removal of the gland, because especially on clinical examination, a tumor mass or the process is firm, it's hard, and clinically must be thought likely to be a cancer. When the gland is explored, however, and the typical pathology found, conservative surgical therapy can be carried out. Riedel-Struma presents itself as a very firm, hard gland, and on clinical examination must be suspected of being cancer. This process is seen very infrequently. In our experience, in the surgical specimens, only 1 in 1 to 2,000 specimens. In these cases, when the process is identified at the time of surgery because of its gross appearance, the invasion of the gland, or the invasion of the adjacent tissues, it's not necessary to totally remove the thyroid gland, but certainly the trachea should be freed up to prevent obstruction to the airway, and given time, the process most frequently will gradually subside. Now then, when we come to adenomas, certainly adenomas of the thyroid gland comprise the largest number of non-functioning tumors of the thyroid gland. When one considers adenomas of the thyroid gland, he must consider the multiple potential hazards of the gland, because since these tumors are non-functioning, at least these are the ones we're talking about at the moment, one has no basis to remove a non-functioning gland or nodule which is causing no symptoms unless he feels that potentially the hazards for the future of that gland are significant to the patient. And one must think naturally of the variety of hazards and not state his case only on one. One hazard that can occur to a nodular goiter, the symptoms of pressure in the thoracic inlet, and I point out how important it is to consider the subsequent cosmetic problem that might be created, as well as the other problems, potential complications of a goiter. The risk of cancer occurring in a nodular goiter, a non-functioning goiter, becomes extremely important. And one can search the literature and find figures of all amounts. One might imply from any figures that are quoted that we would recommend removal of all nodular goiters, but this is not true. In fact, at our institution, we remove only 10 to 20% of asymptomatic nodular goiters. The older patient with a small to moderate size adenomatous goiter of long duration, without change in size, without discrete firm nodules, is usually not operated upon. Whereas a younger patient with a firm, discrete or single nodule of short duration, with some increase in size, cold on scan, would be urged to have the goiter removed. Then naturally we have gradations between these two extremes. Now then, as far as cancers are concerned, non-functioning tumors of the thyroid gland, we must appreciate the variation in the biologic behavior of the several types of thyroid cancer, and this must be recognized if the proper treatment is to be offered the patient. In a review of 1,181 cases, 62% of the cases fell into the group that we considered papillary adenocarcinoma. This included not only the pure papillary lesions, but also those that were mixed papillary and follicular. 18% were the pure follicular, 6% medullary carcinoma, and 14% anaplastic. The prognosis of papillary cancer, from our standpoint, relates really to the size of the primary lesion. For this reason, we've divided these types of tumors into three categories: the occult, lesions which are 1.5 centimeters or less in size; intrathyroidal, where the tumor is greater than that size but remains within the thyroid capsule; and extrathyroidal, where the tumor mass invades the capsule of the thyroid gland or the adjacent structures. For the most part, a papillary cancer of the thyroid gland is treated by a total lobectomy on the side of the lesion and a subtotal on the opposite side, unless the lesion is multicentric bilaterally. The reason we prefer to be conservative on the opposite side of the neck is the fact that we want to maintain a minimum instance of permanent tetany and cord paralysis. And in our institution, in dealing with lesions of this type treated this way, the instance of tetany is 0.3%, and also the instance of permanent cord paralysis is 0.3%. But during a 40-year follow-up in these patients, 244 fell in the occult group, and even though 39% of these patients had regional metastases, no patient died during this period of the follow-up. And for the regional metastases, either nothing was done in the neck when there was no clinical or gross evidence of regional metastasis, or a modified neck dissection was done in 90% of the cases in which regional metastasis was suspected, and in only 10% of the patients with nodes was a radical neck dissection done. When the lesion remained intrathyroidal, again, even though almost 50% of the patients had regional metastasis, there was only a 3% instance of mortality during the follow-up period. Of significance is the fact that when the primary lesion becomes extrathyroidal, the mortality occurs. Now then, going on to the follicular carcinoma of the thyroid gland, even though this lesion spreads occasionally to the regional lymph nodes. It's infrequent. For the true follicular lesion, the prognosis is related to the presence or absence of invasion of the tumor. And in 208 cases, the series was divided about equally. This lesion is the lesion, because of its invasion, that spreads distantly. Therefore, it can be treated differently than the papillary lesion. A neck dissection is rarely indicated for this lesion, but I think one could argue that because of the fact that this lesion, especially in the absence of remaining normal thyroid tissue, does function, and for this reason, it's well at the time of the primary surgery to consider a total thyroidectomy, and this is especially true when there's evidence either on a fresh frozen section examination or grossly of invasion, because in so doing then the patient is better prepared for subsequent radioactive iodine therapy. We go now then to the medullary carcinoma, or the solid carcinoma with amyloid stroma. This lesion is more aggressive. It spreads both to the regional lymphatics and distantly, and in this instance, because of the biologic behavior, the prognosis is related to the presence or absence of lymph nodes. This is the lesion that is related to the multiple endocrine syndrome, in some instances, most often the presence of pheochromocytomas, and once again, these lesions do occasionally function. Whenever lymphadenopathy is present with this type of non-functioning tumor of the thyroid gland, probably a radical neck dissection is indicated, because the prognosis is tied to the presence of lymph nodes. We come then to the last group of thyroid cancers, non-functioning tumors, the anaplastic cancer. The anaplastic cancers come in a variety of cellular types. The prognosis for these lesions is extremely poor, almost all of the patients dying in a period of less than 1 year, and almost all dead within a period of 2 to 3 years. Unfortunately, surgical therapy is not effective in many of these cases, irrespective of how extensive the surgical procedure might be.
The conclusion of Dr. Beer's presentation also concludes this side of your reel, Doctor. The remainder of this program on thyroid and parathyroid tumors may be heard by simply reversing the 2 reels or cassette cartridge on your tape recorder. A panel discussion on thyroid and parathyroid tumors, 1970, continues now on this side B of Audio Digest Surgery, Volume 17, Number 1. Once again, our program moderator, Dr. J. Engelbert Dunphy.
The next presentation will be by Dr. Martin Black, who will speak to us on hyperparathyroidism. Martin?
To a degree almost unprecedented in clinical medicine, the diagnosis of hyperparathyroidism rests on calcium determinations of extraordinary accuracy. Until very recently, the usual hospital laboratory was quite incapable of providing you with such determinations. Within the last 3 or 4 years, an entirely new method of determining serum calcium has developed. This is one of the 12 tests carried out by the very popular autoanalyzer, and the results of the test are quite adequate to differentiate hyperparathyroidism from the isoparathyroid state. As a result, it's been possible to carry out surveys of populations for hyperparathyroidism. It turns out to be that hyperparathyroidism exists in about 1 in 1,000 patients coming to the usual medical clinic. I should perhaps add adult patients. Hyperparathyroidism can be expected in about 1% of patients with ulcers, and it should be suspected in the patient whose ulcer is rather refractory to treatment. With such a vast number of patients with the disease, and such vast numbers of patients indeed are being seen with the use of the autoanalyzer, it's been necessary to change our minds materially on what we ought to do surgically about hyperparathyroidism. In the past, we've largely made the diagnosis on complications of the disease, and there's no question about such patients should still be operated upon. However, the patient who has chemical hyperparathyroidism, to use the common term in the field, who has no complications, or the patient who's had perhaps a kidney stone years back and no evident activity, we ourselves have stopped operating on merely the diagnosis, and we're watching such patients. I would add that this is by no means a final solution. No one has ever followed proved cases of hyperparathyroidism without complications for indefinite periods, and we don't know what's to happen to them. If they begin to get into trouble in due time, we shall have to revise our current opinion. I needn't emphasize to this audience particularly that hyperparathyroidism should be considered in all cases of renal lithiasis, in all cases of generalized or metabolic bone disease, in all cases of peptic ulcer, in all cases of pancreatitis, in cases of polyuria, polydipsia, and it's been recognized recently that intractable nausea without apparent cause is very often associated with hyperparathyroidism. If the disease is suspected, the diagnosis ultimately depends upon the demonstration of hypercalcemia. Great emphasis was placed on the excretion of calcium in the urine some years ago. This has been largely abandoned, and considerably more emphasis in recent years has been placed on the excretion of phosphorus in the urine. One of the primary effects of the hormone is to increase the excretion of phosphorus in the urine. It was felt originally that this would not yield as many cases. In recent years, this has been revived, and most people today rely on some phosphate excretion tests, such as the phosphate excretion index or other such tests, to help establishing the diagnosis. I might point out that phosphate excretion tests are profoundly influenced by phosphate intake. The tests get better the longer the patient is kept on a balanced phosphate diet. This becomes impractical clinically beyond a few days, and the usual OB diet has been employed in the past. The diagnosis, I might add finally, hyperparathyroidism, curiously, has rarely been discovered in large numbers of cases unless a special interest was developed in the famous stone clinics, the stone quarries, the hyperparathyroid clinics, what have you, an endocrinologist, the internist. And I might add further that it's rarely treated satisfactorily unless the pathologist and the surgeon have a very special interest in it. And of course, the cases are still found primarily on urologic wards, where some 5 to perhaps even 15% of patients with renal lithiasis have the disease. The stone pattern can be anything, and even the stones of gout, the uric acid stones of gout, yield a very high proportion of patients with hyperparathyroidism. As surgeons, we must, of course, recognize the pathology. About 90% of cases, it's a solitary adenoma. Multiple single adenomas occur, and this has profound theoretic implications. If you can have 2 parathyroid adenomas at the same time, surely you can have 2 parathyroid adenomas at different times. Recurrences, therefore, may be expected. Fortunately, they're very rare, but a handful of cases have been reported. Wasser-Heli-cell hyperplasia is a fascinating condition for reasons totally unknown. The upper glands seem to be often bigger, the lower glands are smaller. The monotonous pathology, this should be easily recognized from fresh frozen section, and important because, of course, one must carry out a subtotal resection or the patient won't be cured. This is a true primary hyperplasia of the parathyroid. The clear fluid in the cells, presumably, is hormone. The parathyroidal disease itself is usually not very intense, and patients may have huge amounts of this. Our largest patient had 52.5 grams of tissue of this kind. When you realize that the 4 parathyroids weigh collectively about 125 milligrams, this represents a 5,000-fold hypertrophy of tissue, the like of which is not to be found in human pathology elsewhere. Now, some years ago, we described something that we called adenomatosis of the parathyroids. We envisioned it as something like adenomatous goiter. The glands are not necessarily all involved, but you've got a little bit of involvement here, a little bit of involvement there, a lot of involvement here, and the 4th gland normal. In 1958, Castleman, the pathologist involved at the Mass General Hospital, proposed there was another hyperparathyroid state due to primary chief cell hyperplasia. You appreciate that when there is renal insufficiency or when the calcium tends to fall for any reason, the parathyroid's hypertrophy. This is a classic picture of a chief cell hyperplasia, and they proposed that now there could be a primary chief cell hyperplasia without evident cause, hence the term primary. We rather stubbornly wanted to call it adenomatosis. Because of the tremendous interest and the opportunity to examine parathyroid glands in huge numbers of patients with renal insufficiency, it's very likely that we're both right. In retrospect, we were dealing with polyendocrine adenomas, adenomas in various organs of the body, the pancreas, the pituitary, the parathyroids particularly. Their material, for the most part, had to do with patients with renal insufficiency or familial hyperparathyroidism. The pathologist, again to emphasize, has had great difficulty distinguishing what these are, and I might add the same thing holds for adenomatous goiter. Hyperplasia and adenomas of the thyroid seem to present a great problem to the pathologist. The important thing to remember, is that when you have a family history of hyperparathyroidism, when you have renal insufficiency, when you have a family history of very difficult peptic ulcer, think of the involvement of all 4 glands from the surgical standpoint. Chances are you're going to find multiple glandular involvement, and very likely you're going to find the involvement of 4 glands. As far as the surgery is concerned, the only definitive treatment of the condition is surgical, and it involves identifying the 4 parathyroid glands and, of course, removing the bad one in 90% of the cases, a subtotal resection in others. Cancers, I suspect, are incurable. I always challenge the cured case of carcinoma of the thyroid because actually most of them have not been cured, and you find a good deal of pathological uncertainty, and this, again, is by no means limited to the parathyroid field. It's characteristic of all endocrine neoplasia. If the parathyroid is associated with the thymus, which is not at all uncommon, it undoubtedly shares a blood supply with the thymus and almost certainly will not be devascularized if one does a total thyroidectomy. One of the main problems, of course, in doing total thyroidectomy is to avoid tetany. The parathyroids may also be displaced into the chest. The superior gland is far dorsal and usually goes down the tracheoesophageal groove and may get into the superior mediastinum. The inferior gland is usually far enough forward so that it's displaced anteriorly, but it may be displaced posteriorly. The surgeon has a mild hint as to where the gland might be by the level of calcium. There is a rude correlation between the level of serum calcium and the size of the adenoma. Once again, as in other endocrinopathies, by no means as nice as we'd like it. But if you have a calcium of 13 or 14, you're thinking indeed of a 2, 3, or 4 gram tumor. If the calcium is at 10.5 or 10.6, where it usually is, think in terms of a several hundred milligram tumor. The big tumors almost surely will be displaced somewhat and may be displaced well into the mediastinum. The tiny tumors almost certainly won't be displaced into the mediastinum. If you can't find the adenoma, then there are many things that one can do. The operation essentially is to find 4 deposits of parathyroid tissue. While there are exceptions to this, broadly speaking, there are 4 parathyroid glands. Your aim is to prove that 3 are present and 1 is missing if the mediastinum is in the chest. This is about the only time that I think biopsies are permitted. You biopsy the normal glands very carefully to prove that you have them, and then we would prefer, indeed, to wait for 3 months to go and to reprove the diagnosis before proposing that the mediastinum be explored. I might add that parathyroids in the mediastinum not accessible through the cervical incision under direct vision are extraordinarily unusual. As part of the complete cervical dissection, as a matter of course, we look for pedicles leading into the chest. We expect the adenoma to be sizable, hence the blood vessel will be sizable. It takes off from the inferior thyroid artery, and the adenoma easily removed. After having done all that, if you have parathyroids perhaps on one side and a missing gland on the other side, there's no great objection to doing a total thyroid lobectomy, hoping to uncover a small adenoma. If the calcium's high, it's very unlikely that the adenoma will be large and concealed by the thyroid. Well, so is the game, ultimately, when you've had a good deal of experience in treating these people. I would emphasize that the adenomas in the chest that can't be seen and removed under direct vision from the neck on careful dissection occur in not more than 1 to 2% of cases. The surgeon should recognize this before he proposes to explore the chest.
There are a number of questions. Dr. Holden, how much reliance do you place upon the scan in the diagnosis of a hyperfunctioning nodule?
Well, I think in the hands of a person who's thoroughly acquainted with all the problems of scanning, the time relationships, dosage, and so on, that the scan is a very effective diagnostic tool. Now, it is least effective, I think, in patients who have multiple adenomas that are hyperfunctioning. It's also difficult by scan to differentiate on occasion the patient that has a lobulated thyroid gland and truly Graves' disease from the patient that does have multiple adenomas. But generally speaking, it's a most effective way of making a diagnosis of the areas of the thyroid gland that are overactive. Technetium has been used and is being used more frequently. It is least desirable in the patient with multiple nodules in the thyroid. This is where the distinction between technetium and I-131 or any of the other iodine isotopes breaks down. For some other purposes, technetium is a valuable method of scanning, although I personally have had very little experience with it.
Dr. Holden, would you clarify your precise indications for carrying out surgical procedures in a hyperfunctioning thyroid nodule versus treatment with radioactive iodine?
As I mentioned in the paper, in the course of scanning the thyroid for nodular lesions, many hyperfunctioning adenomas will be detected, but a relatively small proportion of these, fewer than 25% of them, will actually be producing symptoms of toxicity. Now, these particular lesions, many people will treat, especially the internists. They'll treat them with antithyroid drugs or even radioactive iodine. Actually, there's probably little reason for treating these lesions, but there is every reason to observe the patient carefully over an extended period of time, because some of these ultimately will produce mild symptoms of thyrotoxicosis. At any time that they do produce symptoms of thyrotoxicosis, I feel they should be treated surgically unless there are specific contraindications to surgery. And some of these are the extremely elderly patient, the patient with extensive concurrent disease, with a limited lifespan because of other diseases, and things of this sort. But generally speaking, I think the treatment of the toxic adenoma should be surgical. It's the cleanest, most definitive way of correcting the disease promptly.
Dr. Beers, would you agree with that?
I would agree in general. Certainly, surgical treatment of a toxic nodule is not only definitive, but it's immediately effective. And even though from the surgical standpoint, this is my philosophy, I think we have to admit that with radioactive iodine being available in the hands of internists interested in this disease, many of them are being treated medically by the internists, where if we had seen them from the surgical standpoint, they would be treated surgically.
Dr. Black, would you
I've just reviewed the literature on this, and I can give you a box score, but I won't. In general, you have to get pretty far into Woodian woods before you'll find an internist that thinks he should treat this way.
Well, I think you'll see, gentlemen, a general drift on the part of internists back towards far more precisely selected surgical intervention in the treatment of toxic thyroid states of all types. Dr. Holden, relating to your technical approach to a patient who appears to have a hyperfunctioning solitary nodule, do you just go right ahead and do a total lobectomy? Do you open the gland? How do you try to do this excisional therapy that you described?
Well, most of these are discrete adenomas. And if you know ahead of time, frequently by the scan, whether you're dealing with a single large adenoma or multiple adenomas, if it is a single large adenoma, the remainder of the gland has to be examined very carefully because the scan is not perfect by any means. But if it is a single large adenoma, I try to enucleate that adenoma and preserve all of the remaining tissue. If it's multiple adenomas scattered throughout both lobes, then you've got to do a subtotal thyroidectomy, and after having done this, you've got to examine the thyroid tissue attached to the posterior capsule to be sure that some small adenoma has not been left behind.
Would you like to comment on thyrocalcitonin and any practical implications of studies of thyrocalcitonin levels in thyroid surgery?
Well, it has been demonstrated that at any time a large portion of the thyroid gland is either removed surgically or ablated, it very likely creates a deficiency of calcitonin. Now, the clinical significance of this, I think, still remains to be demonstrated and proved, because about the only way, aside from some very complex techniques, that you can demonstrate a thyrocalcitonin deficiency is by doing a calcium tolerance test. And in patients who have had extensive subtotal thyroidectomies or have had their gland ablated with radioiodine, you can demonstrate abnormalities in calcium tolerance. Again, the significance of this, I haven't any idea.
One of the questions which has come in several forms, but is basically the same, is directed to Dr. Beers, and it relates to the magnitude of surgery which should be performed for papillary carcinoma of the thyroid. Now, the first phase of this question simply says, do you ever perform a prophylactic neck dissection for papillary carcinoma of the thyroid? Dr. Beers.
No, not prophylactic.
Now, the second phase of this is, what if the tumor is described as, quote, papillary follicular?
In our experience with Dr. Woolner reviewing the tissues, we found that any cancer that has any papillary component biologically behaves as a pure papillary cancer. For that reason, we leave papillary cancers, mixed papillary and follicular cancers, in one group.
So that if the tumor shows any papillary change at all, you classify it as a tumor of relative benignity, so to speak.
That's correct.
Now, when would you perform a neck dissection for a tumor of the thyroid that had papillary elements in it?
Whenever there is clinically a lymphadenopathy present, or grossly at the time of the surgery lymphadenopathy is present, we would extend the operation into the lateral neck. 9 times out of 10, we would do what we consider a modified neck dissection, which implies something less than a radical neck dissection. This procedure, however, might be as extensive as a radical neck dissection, except that the sternocleidomastoid muscle and the contents of the anterior cervical triangle are not removed. In only 10% of those cases having findings in the lateral neck would we do a radical neck dissection, and this judgment is made on the basis that there's extensive nodal involvement, and this is the only practical way to remove the lesions.
In other words, it's almost a mechanical decision on the basis of the extent of the nodal involvement.
That's correct.
Dr. Beers, what do you do for the papillary carcinoma patient in whom the tumor first appears in the lymph nodes? Well, let's put it this way. You have 2 choices. You have a patient sent to you who has had a excision of a nodule in his neck which turns out to be carcinoma or papillary carcinoma. Or the other alternative, you suspect a patient has a nodule rather low in the neck, might be consistent with it. How would you approach these 2 issues?
Yes, 22% of our occult papillary adenocarcinomas of the thyroid are discovered in this manner. Either the nodule has been removed elsewhere and the diagnosis established, or we might suspect it at the time of our initial examination. Fortunately, our surgical pathologists are in a position, because of their experience, to not only establish the fact that a lesion is a cancer of the thyroid gland on fresh frozen section diagnosis, and also they will classify it by this method. Therefore, in the operating room, when a node is removed and the pathologist says it's a papillary cancer, we're prepared to move right ahead and explore the thyroid gland. Now, as you recall, historically, these lesions that were removed from the lateral neck on occasions were considered to be lateral aberrant thyroid tissue, not necessarily papillary cancer. But I think from the practical standpoint, whenever tissue is found in the lateral thyroid region, the thyroid gland should be exposed, and in almost all instances, a small primary lesion will be found in the gland, even though none is felt clinically.
Do you use thyroid suppression therapy following operations for papillary carcinoma?
I use it for 2 reasons. The primary reason is the fact that we've done a total lobectomy on one side, we've done a subtotal or partial on the other side, leaving 1 to 2 grams of thyroid tissue. This most often is insufficient in amount to prevent myxedema from developing. For this reason, in order to keep the patient euthyroid, I would place these patients on thyroid replacement therapy. Secondly, if by chance there is some truth to the fact that these lesions are hormonal dependent, the patient is going to benefit in this respect also.
Would any of the panel do a prophylactic node dissection for medullary carcinoma? Dr. Black?
No, I don't think so. Based on 51 cases, patients that had no nodes when we first saw them got no nodes as they were followed from that time until 7 or 8 years, the longest follow-up.
Dr. Beers?
They have nodes or they don't.
I would agree. If there's no lymphadenopathy clinically or grossly at the time of the surgery, no neck dissection. However, if there is lymphadenopathy, either obviously cancer or suspicious, then I would do a radical neck dissection for this particular type of lesion because it's more aggressive and the biologic behavior is different than the papillary cancer.
Would you do a mediastinal dissection?
No.
Supposing that as you were doing your radical neck dissection, you found a very definite chain running down into the mediastinum.
Whenever a thyroidectomy, either total or less than total, is done for any cancer, I always examine the tracheoesophageal chain of nodes, and these are dissected free from the tracheoesophageal groove and down into the mediastinum if the lymphadenopathy continues downward. But most often, this pathology can be removed through the surgical approach.
Dr. Holden.
One of the things that Dr. Beers alluded to, I think, is of considerable importance. When you're looking for lymph nodes in the neck, the first place to look is in the tracheoesophageal sulcus, rather than out in the lateral cervical chain, because frequently nodes will be positive there, and there are no palpable or grossly enlarged nodes in the cervical chain itself.
Of course, this is a point that George Cryle made, emphasizing that the so-called classical standard neck dissection might actually overlook the nodes in the tracheoesophageal angle. We have done some rather extensive mediastinal dissections for medullary carcinoma. I think it's a little early to say how profitable it is, but this seems to me to be one tumor that does have an aggressive lymph node involvement that still seems to respond fairly well to radical surgery. Would you just sum that up again, Dr. Beers? Do you think we're wrong to go into the neck and go into the mediastinum?
No, I do not. The medullary cancer is aggressive. Patients do die because of nodal spread, as illustrated by our follow-up studies. And since this is true, this is the lesion. It's only a group of 6% of the total lesions that should be treated more radically. And when I say more radically, I think one has to consider a total thyroidectomy in many or most of these cases, because this lesion also is multicentric. And then whenever there's any question regarding spread beyond the confines of the thyroid, a radical neck dissection, and I wouldn't deny the fact that a mediastinal dissection in the future might be indicated also, but based on our experience at the present, we can't say yes or no to that.
Dr. Black, what is the best single diagnostic test for hyperparathyroidism?
The serum calcium determination.
Do you use toluid and blue infusions to help you identify parathyroid glands?
No, I think ordinarily they're very easily identified. Toluid and blue isn't, of course, not without some toxicity. If you give it locally, you stain the thyroid a bit, and you have to wait quite a while to show up the parathyroid. And, of course, the parathyroid itself may not show.
Have you actually used it?
No. We've not been tempted to at all in the human.
How about selenomethionine?
No, time's running out. I defy any of the methionine boys to read an unknown scan.
Right. In other words, you feel that having the diagnosis, which is an elevated calcium, the best therapy is to send the patient to black.
Well, no, the next step, and I didn't have time to develop it, you're faced, of course, with a differential diagnosis of hypercalcemia. And when the commonest cause of hypercalcemia today, far and away, is malignancy. And the malignancy may be occult. And certain malignancies produce a substance very similar to parathyroid hormone. Now you're getting into the tough areas.
What about steroid suppression in patients with
once again,
hypercalcemia?
the cancer producing a parathyroid-like substance, which is very close indeed to parathyroid hormone, will suppress poorly, if not at all. The cancers that produce something like vitamin D suppress readily. Usually it gets you off the hook, but not always.
What would be your therapy for parathyroid carcinoma?
First of all, we hate to biopsy it. Biopsy has been followed by a far, far too great a number of local implants. You make a good solid guess whether it's cancer, and you go at it as radically as you possibly dare. As I implied from my presentation, if you cure them, we feel as it stands today, there's a good deal of doubt as to whether it was malignant or not. Another convention in the field, if they haven't got hypercalcemia, the pathologists are rather reluctant to make a diagnosis of non-functioning parathyroid carcinoma because they can mimic thyroidal cancers so closely. I don't know why we can't cure them. They're low grade. It's just that they infiltrate so readily, I guess, once they get to the capsule.
Well, we've essentially come to the end of this session. I want to thank the panelists for what I regard as really superb presentations.
And those remarks conclude this edition of Audio Digest Surgery. Our thanks to all participants and to the American College of Surgeons for cooperation in recording and distributing this material. Audio Digest Surgery, produced by the Audio Digest Foundation as a nonprofit subsidiary of the California Medical Association, is produced twice each month, along with 7 other programs of tape-recorded postgraduate medical education. All material in this program is copyrighted, and further tape duplication is prohibited.